So first of all, very good evening to all my delegates. Here is our uh, Dr. Respected Dr. Madhusudan Agarwal, and this is President SARC Association of Urological Surgeons, also Head of Department of Urology, Global Rainbow Healthcare Agra. So welcome, sir, and thanks for giving your valuable time. So over to you, sir.
Well, friends, thanks for this opportunity and the invitation. And I have the pleasant task of discussing with you um, in brief the medical management of BPH and the current thinking about it. Now, we all know that BPH is one of the commonest diseases which affects males. And what I'm going to speak about, I think most of it is already known to all of you. So maybe what I'm going to say, not much of it is going to be new to you, but I'll just briefly summarize the current state of knowledge about BPH, and I will skip the common things which are well known to everybody, and I'll just focus on some of the newer things or the current thinking, and we are going to focus on medical management only. So why are the slides not moving? Yeah. So as we all understand, and this is a very commonly asked question by patients, that why is it happening? मैं तो डॉक्टर साहब सिगरेट भी नहीं पीता हूँ और बहुत सात्विक जीवन से रहता हूँ, मेरे को ये क्यों हो रही है परेशानी? So this is the standard answer, that BPH is in men is a process of aging, and just like the cataract, you can expect it to happen in almost everybody. So this is something which Sir Benjamin Brodie had, one of the pearls from Sir Benjamin Brodie. Just like cataract, you can expect this to happen to almost everybody. And there is statistics to confirm this, that almost 100% of people by the age of 90 will have enlargement of prostate. But it is also important to remember that not everyone who has enlargement of prostate will be symptomatic. So only about half the people who have enlarged prostate will be symptomatic, which means the prostate will be obstructive or will cause symptoms. And by and large, it is expected that about 1 in 10 will require surgery. Now, with improved medical management, this figure has actually become even less. Another important thing to remember is that BPH actually is a combination of several things, not only enlargement of prostate. And this is important because in today's time, when ultrasound has become standard method of screening for everything from headache to toothache, enlarged prostate is reported in almost everybody, even in the 30s. So just because the ultrasound suggests an enlarged prostate doesn't make somebody a patient of BPH. You have to have enlargement of prostate, you have to have obstruction in the flow of urine, demonstrable by investigations, by proper tests, and you have to be symptomatic because of that to qualify as a patient of BPH. This is very important. Now, another important thing is that not all people who are symptomatic because of BPH will have progression of the symptoms and will require intervention, because almost half the people, or at least 40% of the people, will not worsen, will not progress, and their symptoms remain stable. And this is another reason why many of these patients can be managed with conservative treatment. Now, there are studies, long-term studies actually, which have shown that progression is observed in a fair percentage of patients, but the variable reports. Some people say 20%, some people will say 50%, but not in all patients. And it has been also estimated that people who present with relatively severe symptoms or relatively severe parameters like total prostate volume, more than 30 PSA on the higher side, low flow at the time of presentation, or high post-word residue, are the people who are more likely to progress as compared to the people who present with less obstructive symptoms or smaller enlargements of the gland. Another thing which we have to keep in mind when prescribing or planning treatment is that at this age, that is after the age of 40, 50, or 60, many of these patients will have comorbidities, diabetes, hypertension, cardiovascular diseases, and many men will come with erectile dysfunction, something which they do not volunteer at the time of initial presentation, but they will confide this to their urologist later on or on direct questioning. So these things also have to be kept in mind when treatment is being prescribed. So when these people are being diagnosed or when they are put on treatment, and this is something which I'll like to address to my physician friends, they should not be treated with an armchair kind of approach, that somebody comes with symptoms and he's just prescribed an alpha blocker. Now that's something which I see very often our general practitioners and physicians do. The person with symptoms of BPH has to be properly evaluated before he is started on treatment. And this includes proper detailed medical history, including the symptom scoring, detailed physical examination, and proper investigations, the standard urine examination, blood chemistry, in addition to ultrasonography, and if required, transrectal ultrasonography, PSA, and in selected cases, urodynamic evaluation. Now, there are some tests which are done in everybody, like standard blood chemistry and urine examination and PSA in everyone and ultrasound in everyone. But some important parts are nearly always missed, like detailed proper medical history, physical examination, and simple urodynamic tests like uroflowmetry, which are probably more important than the tests which are routinely done. So a digital rectal examination is a very important and something not to be missed evaluation in these patients before they have started on treatment. And again, this requires a specialist's evaluation, really speaking. So similarly, serum PSA is a good test for screening, and although it is technically not necessary in every patient, but nowadays it is very difficult to skip this, because if you don't ask it, somebody else will, and even the patient will ask for a PSA. So you might as well prescribe it as the initial test along with all other blood tests. And we all know the normal range of PSA and so on and so forth. And so many people who ask for and undergo biopsies just because the PSA is marginally raised. It's important to remember that PSA is raised not only in malignancy, but in a host of other conditions like even BPH, and very commonly because of inflammation, prostatitis, and even simple UTI. The important test which I would like to emphasize upon, which requires to be done in most of these patients to establish the diagnosis, is uroflowmetry, because this will actually establish that there is indeed obstruction to the flow. So this is a curve, a normal urine flow, and if the flow is obstructed, if the peak flow is reduced, if the flow time is increased, this test alone will confirm that the patient is actually obstructed to qualify as BPH, not just because the ultrasound shows a large prostate, and also the post-word residue which should be examined on ultrasound before you can say that this patient requires treatment. CMG or the cystometrography or the detailed urodynamic study is required in patients who are suspected to have neurogenic component to their problem, and this is not required in all patients, should be done only in selected cases. Now, coming to management, as compared to the past, there has been a steady decline in the patients that are requiring surgery, and more people are now being managed with medical treatment, and that is why medical treatment has become important. And the mainstay of medical treatment is the alpha blockers. Now, we all know what alpha blockers are, so I will not go into any details, but we also understand that it is the selective alpha blockers. So we are focusing on alpha 1 and even in that category, alpha 1A selective blockers. And this is the list that all of you are familiar with. We all started with the non-selective alpha blockers, then we went to the selective alpha blockers, and doxazosin, terazosin. Terazosin was the one which came first of all, but nowadays we are using mostly tamsulosin, alfuzosin, and silodosin. These are the ones which are most commonly used. Since alpha blockers are also have anti-hypertensive role, so initially the non-selective alpha blockers were serving the purpose of reducing blood pressure also, like terazosin. But most guidelines nowadays suggest that we should treat them separately. The anti-hypertensive role should be done by antihypertensives, and the medicines for prostate should be considered separately. Alpha blockers should not be considered as monotherapy as antihypertensives. And we have to be careful in selecting the medicines for BPH in patients who are receiving antihypertensives. Among the alpha blockers which are in use, the most selective alpha 1A alpha blocker is silodosin currently. Tamsulosin is the one which was most widely used for many years, but as compared to tamsulosin, you can see here that silodosin has much higher selectivity, in fact more than any other alpha blocker. Now, in clinical use, multiple studies have demonstrated that for voiding and storage symptoms and overall, there is significant improvement when silodosin is used, in improvement in all parameters, especially symptom score, using silodosin. Especially in nocturia, as compared to other alpha blockers, silodosin has demonstrated better results than the other less selective alpha blockers. So there is significant reduction in nocturia, and which is among the most troublesome symptoms in patients with BPH. In fact, one of the first things that bothers a patient of BPH is need to get up several times at night to pass urine, which disturbs the sleep. Another benefit of silodosin is that it is much faster acting as compared to other alpha blockers. So whereas with tamsulosin, the standard teaching was that it takes 2 to 3 weeks for the symptoms, the peak effect to come. With silodosin, it is within a few days, actually, you would find that the effect comes. And you don't have to wait for several weeks for the maximum benefit to arrive. And this is something which is very important from the patient's point of view. And in today's time, we all understand that nobody has the patience to wait for a long time. The patient will go away to another doctor if he is not relieved within a few days. In fact, within the first, second dose, you will find benefit with silodosin. And this improvement is sustained over a long period of time. In many studies, it has been demonstrated. Another major benefit of this selectivity in silodosin is that it is completely safe in patients with cardiovascular diseases and in hypertensive patients, because it has least propensity to produce orthostatic hypotension. One of the biggest problems with alpha blockers used in BPH was the problem of orthostatic hypotension, especially the first dose hypotension. So celedosin is relatively safe. In fact, it's very rare for celedosin to produce hypotension. So the standard dose of celedosin of 8 milligram per day is safe. Normally, alpha blockers are given at night, but this can be given actually any time of the day. And very rarely you have to reduce to 4 milligram a day in patients who have low blood pressure or who demonstrate hypotension. In my practice, I've seen that maybe 1 in 100 or 2 in 100 would ever report this side effect. And these are multiple studies which have demonstrated that there is no fall in blood pressure with this medicine. And patients who are receiving other antihypertensives, these are the ones who are especially prone for fall in blood pressure with other antihypertensives like tamsulosin or especially with elfusicin. So this is where celedosin is beneficial. The dizziness, other side effects are also much less, and withdrawal of treatment because of this reason is less with celedosin. There is one side effect with celedosin which is very common, and in fact this result has kind of underestimated this, that is ejaculatory dysfunction. Majority of patients with celedosin will have an ejaculation as compared to any other alpha blocker. Now, it's very special. Only celedosin produces this. Others also do, like tamsulosin has a small incidence, maybe 10 to 20%, but a vast majority of patients with celedosin will have ejaculatory dysfunction. They have anejaculation. There is, they don't have anorgasmia, they don't have erectile dysfunction, but they have anejaculation. Now, this does not interfere with normal sexual function, and many people get used to it. So, patients who have erectile dysfunction, it is not that you cannot use sildenafil, celedosin in them, and in fact, you can combine sildenafil or tadalafil with these patients because the risk of fall in blood pressure is less with celedosin. Since tadalafil and sildenafil can cause fall in blood pressure, so combining these drugs with other antihypertensives and with other alpha blockers has a greater risk of fall in blood pressure. So the advantage of celedosin is that you can combine with these drugs and the risk of fall in blood pressure is less. The only thing is that patient needs to be explained about the risk of dry ejaculation or anejaculation, and many people get used to it, and in fact some people may be actually quite happy with that. As I said, no blood pressure fall, no dizziness or weakness, so people may be happy, but at the same time in actual practice, you find many people coming back and complaining about anejaculation. And in general practice, we avoid prescribing celedosin to younger people unless they are okay with this symptom. So if it's a person 50 or in his 50s, sexually active, it's always important to warn the person that he may have this symptom before you prescribe that person this drug. And recently I got a gentleman who's 70 plus, and I prescribed him celedosin, and he came back and quietly he asked for, you know, others to be sent out of the room, and in privacy he confided with me that well, doctor, I want a very private consultation with you, that although I'm 70 plus, but I have to report to you that when I have sex, I don't have any ejaculation anymore. So is this because of age or is this because of the medicine? So that's how it is. Um, Now, in patients who have retention of urine because of BPH, they are the people who would actually require uh, surgery by and large. But somebody who has the first time retention, you can sometimes give them a trial of catheter removal, what is called TWOC, trial without catheter. And you can do that by starting them on alpha blocker and then removal of catheter after 3 to 5 or 7 days. And out of the other alpha blockers, out of all the other alpha blockers, silodosin has shown the best success of TWOC after catheter removal. So in about 2/3 of the patients, if it is a first time retention without other side effects like chronic retention, recurrent UTI, hematuria, stone, if somebody has or uremia, if somebody has chronic retention, if somebody has multiple other side effects, uremia, back pressure changes, then it is not advisable to remove catheter or avoid surgery. Then the patient should go for surgery. But if somebody has first time retention, previously not too much symptomatic, no other complications, then one can give a trial of catheter removal and put the patient on continued alpha blockers and see that he passes well. Now, another important thing is the combination therapy. Use alpha blocker and 5-alpha reductase inhibitor, that is dutasteride. Finasteride or dutasteride. Nowadays, we are using dutasteride more than finasteride. So the 5-alpha reductase inhibitor will arrest the progression of the prostatic enlargement. In fact, it can cause the regression of the prostate size, whereas the alpha blocker will reduce the smooth muscle tone and improve the flow. So this combination actually works very well. And there are studies, and one of the important studies was called MTOPS, which for the first time showed that as compared to finasteride alone or alpha blocker alone, the combination therapy showed the best results. So you can see that 30 as compared to 39 or 34%, there was 66% reduction in progression with combination therapy in this study. And there was another very landmark study called COMBAT trial, which again showed that the combination had 44% reduction as compared to 17 and 21% with single therapies. So these two trials established the role of combination therapy. And ever since that time, combination therapy has now become standard management. So alpha blocker will quickly reduce symptoms, whereas dutasteride or 5-alpha reductase inhibitor will reduce the progression. So the only downside is that it increases the cost of treatment, but otherwise this combination is very well accepted. And nowadays almost all patients, most of the patients at least, are put on this combination therapy, and it works very well in giving relief as well as arresting or reducing the progression of the disease and reducing the need for surgery. I think that is the most important thing. So in retention of urine also, this combination works very well, and the combination improves the symptom score, PSA levels, reduces prostate volume. In all parameters, there is improvement, and it is quite safe, well tolerated. There are very few side effects, and by and large, as I said, the only downside is the relatively higher cost. Now, one more thing which has happened in the recent days is using a combination of alpha blocker with anti-muscarinics. Now, anti-muscarinics are anticholinergic drugs which reduce the bladder contractility, and this is come about because of the realization that many of these patients exhibit symptoms of, many of the patients of BPH exhibit symptoms of overactive bladder because of the irritability of the detrusor. So they have hyper-excitability of the detrusor, and this results in increased frequency. So you give this drug the anticholinergics, and this reduces the bladder irritability and the symptoms of increased frequency. Now, we've come back to that ejaculatory dysfunction business that we have just discussed. I think we have already talked about this. So, as I said, an ejaculation has to be accepted when you are giving silodosin. If the patient accepts it, you continue. If the patient doesn't like it, you have to change the medicine. So to conclude, in view of the comorbidities, it is best to choose an alpha blocker which is effective as well as safe. And silodosin is a drug which fits the bill because it is good in patients who have other diseases like diabetes, not so much with diabetes, but at least hypertension and cardiovascular disease. And it improves all the urodynamic parameters and gives symptomatic relief and helps in avoiding surgery in combination with dutasteride. And it can be used with both dutasteride as well as in patients who have erectile dysfunction with tadalafil. And except for ejaculatory dysfunction, there is no significant problem with silodosin. In fact, it is said that patients who have ejaculatory dysfunction have a better response with this medicine. So, so thank you very much. I think most of what I've said is already known to you, but the fact remains that when I started my practice, there was hardly any medicine available for BPH, and if the symptoms got worse, one had to get surgery done. That was it. But now we have so many medicines, and many of these patients do not require surgery. Thank you. So if there are any questions, I'll be happy to take.
Yes, sir. Thanks for giving your valuable time, and it was very best presentation. And there is some question, sir. So I would like to present there.
Okay, so
Sir,
in hypertensive patients, which alpha blocker is safe? In hypertensive patients, silodosin is safe because it does not interfere with other antihypertensives, and the antihypertensive will keep on doing its job, and silodosin will only take care of the BPH element. It will not cause fall in blood pressure. The second question is, what should be avoided in BPH patients like food and beverages? You see, there is no specific dietary restriction about BPH, but since nocturia is a big problem in BPH, if somebody takes fluids at night, then the nocturia problem becomes worse. So the usual recommendation is to avoid beverages, especially the ones which cause diuresis at night. So we ask the patient to cut down on fluid intake, maybe 1 or 2 hours before going to sleep. So avoid tea and coffee and milk. हमारे देश में सोने से पहले दूध पीने की जो आदत है, उनसे कहते हैं 2 घंटा पहले पी लो. और अल्कोहल वाले लोगों को थोड़ी मुश्किल रहती है. People who are used to taking alcohol before going to bed, it's very difficult to avoid nocturia in those people. So if you cut down on fluids at night, that's the only recommendation. Next question is, when can we start combination therapy of alpha blocker and beta-3 agonists or antimuscarinics? Now, beta-3 agonists and antimuscarinics are required in patients who exhibit more of the storage symptoms. People who have lot of frequency and urgency, and they don't have so much of obstruction. So somebody has increased frequency and urgency and urgent continence, but the uroflowmetry does not show too much obstruction. Now, these are the patients who should be given antimuscarinics. Next question is, which alpha blocker is recommended for expulsion of urinary stones? Any alpha blocker. In fact, all alpha blockers are probably equally good in expulsion of urinary stones. Silodosin is also quite effective. Tamsulosin has been used maximally in studies, but you can use any of them. When we should refer the patient to urologist? Every time, I would say. But yes, the most important thing actually is proper evaluation of the patient rather than just prescribing an alpha blocker on the basis of symptom alone. As I said, just because somebody says that I've got increased frequency of micturition, or just because the ultrasound report says enlarged prostate, does not qualify somebody for an alpha blocker. The patient should be evaluated. Now, if you do your evaluation yourself, that's good enough. But if you want a specialist's opinion, refer to a urologist. The patient should have an ultrasound with post-word residue. The patient should have a uroflowmetry. The patient should have proper symptom scoring. And it should be established that all three things, the symptom should be obstructive, that the patient should not have any other cause for increased frequency like urinary tract infection, the flow should be obstructive, and then you can start. And there should be no other reason like UTI, like diabetes, like malignancy. Exclude everything else and then put the patient on alpha blocker. I think that takes care of all the questions.
Yes, sir. You have given absolutely good answer for that. And now it's the time for conclude. So thank you, sir, for giving your valuable time.
Thank you very much.
Lot of things we have learned from your presentation. And really, it was very good and best presentation, sir.